as Adrienne said, I'm one of the co-founders of the Academy of Perinatal Harm Reduction. We have kind of two goals. We want to we create educational materials, whether that be posters, flyers, trainings, presentations like this one, for staff of pretty much anything. Like, I know that this is a multidisciplinary endeavor, and that's so wonderful because that's what we need. We need people to stop working in silos. So our goal is to kind of create these educational tools that can be used by anybody who touches the lives of a family with substance exposure. And we want to get paid for that and then provide tons of free stuff to people who are actually using substances. We've been building for a couple years. It's kind of slow going. We're certainly not profitable enough yet to start doing what we really want to do. But our main principles are that we insist upon equity, and that means that there's no hierarchy in our business. Everybody gets paid the same amount. Their voices are equally heard. And we also insist upon having the voices of people who use drugs in every level of our organization, from leadership on up. And we hope to eventually replace ourselves with people who don't look like ourselves. So that's APHR, or Academy of Perinatal Harm Reduction. We have tons of free stuff on our website. We're updating it pretty frequently, not like daily, but once a month or so. So you can check that out. It's perinatalharmreduction.org, and the website will be on all of the slides. So don't worry about writing it down. Okay, so let's start with the case presentation. This is mostly based on a real family that I took care of several years ago. And the main tension in this case, as far as I see it, is we as medical providers are always talking about compliance. Is the patient doing what we tell them? It's very paternalistic, and it's not at all patient or family centered. And so I think a better framework to look at this kind of question is through patient retention, because we all have heard 1,000 times, I hope, it's not the person that fails treatment, it's the treatment that fails a person. So that basically means that we as providers and as the creators and upholders of these systems need to think about not ourselves, basically. So this patient was very young, 22 years old. She was married. She was employed as a mother and homemaker, and they only had one car, and it was not super duper reliable. Her husband worked in construction, so he was out the door at like 5 and back quite late, because his work took him, maybe his job site would be 2 hours away that day. So she was very much isolated. Let me see, she lived in a very rural area. So, she could walk to like a 7-Eleven type store, but otherwise there was like nothing. She couldn't even go grocery shopping until the husband got home with the car. And he was very supportive and lovely, and came to all the appointments, came into the hospital all the time. She had been on a waiting list for a treatment space for 4 months. So they had been trying. It just, they had, of course, public insurance and transportation issues, and they also had a 3-year-old. So it was really difficult to find any treatment space that was a fit for her in the first place, and then getting one that her insurance would cover and one that she could actually access. Was really difficult. She had just delivered a few days ago. She was in my NICU with her baby, who had a pretty mild opioid withdrawal, who was on medications, because at this particular facility, that was a given. They did not practice Eat, Sleep, Console, which I hope at least some of you are familiar with, which is a much more parent and non-pharmacological involvement. So when she came to the hospital and got drug tested without her knowledge or consent, and then that was reported to Child Services, they opened a case and began investigating not just the current baby, but whether they would allow her to keep her 3-year-old as well. I will also say that 3-year-old was like the best behaved child I've ever had in the NICU. It, like, you would forget that the kid was there. They just set her up with a coloring book in a corner, and like an hour and a half later, she's like, I need to go to the bathroom. I'm like, whoa, you're still here? Um, so, and she, you know, she had warm clothes and well behaved. They were kind to her, she was kind to them and the baby. And every time I have a patient with child services involvement, I write a note about them, which I think is a good practice for just about anybody, because you know, that's what's going to influence their case. So, you know, sometimes if it's like, oh, this is scary, yes, then you write that note. But in this case, I wrote a note saying, these parents, they're on time, they listen, they ask good questions, their other kid looks great. And then the next day, I actually got a call at home from the social worker asking me to change that note, because that was not the same impression that the social worker got. So there really is a lot of institutional adversarial relationships. I've gotten lots of contacts from social workers saying, well, you can't say that this patient is doing a good job being a mom because we're trying to take their baby away. And I'm like, well, I write them like I see them. So that's really important for all of us that have that ability. If you see something good, write it down, because it's not likely that many folks, many of the people that these folks encounter in our systems are going to do that. Most people, you know, we all want to say that we come from a strengths-based model, but it can be really easy in that kind of toxic and aggressive environment where the power differential is just so much on the side of the hospital. It can be easy to fall into that. Okay, let's go back to this. So she had a C-section. And so she's trying to get into treatment now because that's what the caseworker is requiring. I wrote a huge paragraph under list barriers to treatment, because like, what's not a barrier to treatment for this family right now? Pain, transportation, childcare, finances, literally everything that you need to get into treatment, they did not have. There were also issues of pain. Since her baby was in the NICU and her husband wasn't able to take time off work, she was only taking Tylenol and ibuprofen a week postpartum. I mean, she took her other pain pills for a few days, but so she was doing that so that she could drive into the NICU and see the baby while her husband was at work. And so that is not ideal for many reasons. Social anxiety and hopelessness. She had been involved in our systems a lot, and our systems, while, you know, ostensibly designed to help people, a lot of times can do the opposite and inflict trauma. And all of this uncertainty and all of this wondering if she's even going to be able to mother this baby had been a real barrier to bonding, which all of these negative emotions are triggers for substance use. No history of overdose. She had been using, she had bought some buprenorphine on the street because she had been unable to get on the street. I don't like that term. She had bought some buprenorphine in the community. Allow me to correct my language there. Because she had had issues getting into treatment. So she had tried to do her induction on her own, and that hadn't worked. She wasn't able to afford it, honestly. So she had to go back to other methods. She preferred pills. That was what she had started on about 6 years ago when she was in high school. She had a sports-related injury that never quite healed properly, / was never able to fully stop using her pills. So it started, as a lot of these things do, kind of off and on, and then kind of, you know, one crisis, one tragedy after another in her life ended up being more of a daily thing. So by this point, she was mostly injecting 2 or 3 times a day. And she had used alcohol in the past year, but she stopped when she found out she was pregnant. Can you scroll down for me, please? So can you scroll down to the bottom? There we go. So mostly when she talked about it, she was using to partly for cravings, but then partly for just this intense emotional stress that was all throughout her pregnancy. Most people, when they become pregnant and they have an opioid dependence, they tell themselves, okay, I'm gonna stop and then I'm gonna go get prenatal care. And it just takes longer to stop than they anticipated. And a lot of times it doesn't happen before delivery, which is one of the reasons why we sometimes see later access to prenatal care in these cases. A huge trigger for using again was fear of having her kids taken away and having an open case with CPS. She also had the issue of both of her parents were in recovery from substance use, and they were the kind of supportive that like old school AA tended to breed sometimes. The tough love kind, the kind where they wouldn't babysit her child because they thought that it would help her hit rock bottom. They wouldn't drive her into the hospital. They came in to see the new baby themselves, but they were doing their best, but it was really not helping. She had never sought treatment in the past. Only mental health thing that was actually diagnosed during the hospital stay was PTSD related to prior contact with the medical system, which can be extremely traumatizing for everybody, and especially somebody as stigmatized as a woman who uses substances. And let's see, chronic pain, we already talked about. We talked about that. Only other medications she was taking were prenatal vitamins. And she has been offered long-acting reversal contraception, which she accepted, but they don't do it at a week out. They do it a little bit later usually at the 6-week postpartum appointment. Negative for infectious diseases. And really, I struggled with the recommendations the most. What we really need is a new system, especially when you're doing methadone induction, which for most people involves daily visits for at least, a period of weeks. When you're also trying to navigate postpartum care and caring for another child, our systems are not built for really anybody that we serve, but particularly pregnant people. And I think that in the last couple of years with COVID, we've really seen a big push, mostly led by people who use drugs, by the way, to change the regulations around the methadone system with pretty great success too. People recognized correctly that having a group of 40 people in a small room all waiting for their dose every day was not safe. And so we were able to get different regulations in some places and in some clinics where folks could have take-home dosing or more flexible timing on their dosing. And we realized that efficacy was still good, and we weren't, the sky didn't fall when we released some of these regulations. And so there's a big push now. It started with people who use drugs, and now the literature is following. There's a great study out within the last several months from Mishka Turplin and Andre Jones about, hey, let's rethink this system. And so that's kind of one of the themes that I wanted to talk about today. So I'm gonna pause periodically for questions. Adrienne's gonna help me. So if you have a question, you can put them in the chat, which I am not paying attention to, but I'll pause periodically and Adrienne can let me know if anything pops up. And with that,
I just wanted to, I stopped screen sharing just for a minute, just so we could all see each other. But if you don't mind, we usually just pause for a minute just for questions or comments about the case. So I don't know if anyone has any before we jump into your didactic presentation, but questions for Joelle about this particular case or any comments or recommendations?
I think my only comment is obviously like congratulating her on not contracting hepatitis C. That's a big deal, and making sure that she realizes that she is doing something right. So she's been injecting for plenty of time to have contracted it, and she is the exception. So that's amazing. And I was also thinking about the case recommendation at the end, and how oftentimes there is a tension between people who want to reform the system and people who want to smash the system. And that tension tends to be the people who want to reform the system are in the system and they realize it needs to be reformed and they're like, we just need to do this baby steps. And the people who want to smash it, they're going to die if it doesn't happen now. They're seeing people die every day. And how that is usually where that tension lies, is the immediacy of what needs to change. So yeah, it's a great case presentation.
Oh, thank you.
This is Shauna Anderson from Hushabye Nursery. I just want, hi. So yeah, I just wanted to say, we see this, this is what we do. We work with families who are struggling and who come from a place of so much stigma and not getting the care that they need and thinking this will be it, I'll be able to get into treatment, and the struggle to get into treatment. So I don't know if this is, if this is real and if she's still struggling. I just wanted to say that send her our info if she's got a baby. We'd love to be that person who says, hey, congratulations. As Chris was saying, I think one of the hardest things is these mommies don't hear congratulations. Nobody is saying to them, this is exciting. You have a baby and you're a good mom and look how great your 4-year-old is. And God, you should be so proud of yourself, how you're managing all of this and what can we do to help. And I just think if we have more, thank you for the work you're doing. And if this person is, you said it was mostly based on reality, we would love to be a support to her.
Thank you. It was several years ago and in a state far, far away, but thank you. I am familiar with Hushabye, Shauna. I meant to get in touch with you after my last presentation last year and it didn't happen. So let's make sure that happens this time. Any other comments, questions?
Joelle, I have a quick question. I think it was implied, but it sounded like she didn't have the option to room in at that NICU. But I know you do a lot of traveling clinical care, so I'm just curious, are you seeing that change where there's more options for moms to room in within a NICU? Or
so that particular NICU she could have, but she couldn't because of her 3-year-old. I mean, the kid was lovely for like a couple hours, but you can't keep a 3-year-old in the hospital overnight. And what I'm seeing is that it really depends on something that we don't often talk about, which is just the physical environment. If you don't have private rooms, you're not going to get optimal treatment in your NICU for these patients because it's hard enough to pump your breasts or, hold your baby skin to skin when there's just a thin curtain that might not even go over 5 feet tall. So it really is a matter of hospital administrations making this a priority. What I have seen in a couple of places is they'll have, a few rooms over in a corner that they don't often use. And so they'll designate those as the rooms for these families. But excuse me, I really think NICU care in general needs to go towards private rooms. I'm going off on a little bit of a tangent here, but it's absurd. We don't have ICU patients 6 to a room. Like that's nuts, especially if, babies, they scream a lot. They have a lot of visitors. We really need more private spaces if we're going to do family-centered care. You can't do family-centered care if your room is curtains making a 6x6 enclosure. And so you particularly can't do optimal care for babies that have opioid withdrawal in that environment. You need space, you need rocking chairs, you need a bed for the family, you need a refrigerator for the family, you need a place to store clothes, a place to shower. If we're asking parents to come into the hospital, which we should be because they are our best treatment tool for babies and vice versa, then we need to make a welcoming environment. And we talk a lot about like posters and saying, I'm glad you're here, and saying congratulations and those kinds of things. But we also, like, people have physical bodies that need, food and to be washed and, basic physical needs. Another issue with that I've run into a lot with these kiddos is some of the moms have to leave and go to their methadone clinic every single morning. And sometimes it's an hour to 2 hours away. And that's just a huge barrier to providing family-centered care. I kind of went off on a tangent there. Did that answer your question?
Yeah, you did. Thank you.
Okay.
Any other questions for Joelle before we jump into her presentation?
Their presentation.
I think you're all set.
My pronouns are they, them.
Oh, thank you.
No problem. Okay. I share screen. Here we go. Did I do it? Okay. I always struggle with this. There. Is it up? Okay, cool. All right, let me scooch. I need to make the faces smaller and scooch them to the corner. Okay, I think I've got it. So we're going to be talking about medications for opioid use disorder in pregnancy. I'm Joelle. Hey. A little bit about me. I have been a NICU and postpartum nurse for a really long time in a lot of places. I have also been doing direct service and more administrative managerial stuff for syringe access programs for 11 years. I've presented at a lot of places. My graphic design partner just kind of put a lot of acronyms. That's Harm Reduction Coalition, Drug Policy Alliance, Centers for Disease Control and Prevention, Office of National Drug Control Policy. I always forget this one. American College of Obstetricians and Gynecologists, Academy of Neonatal Nurses, and lots more. I'm also the co-founder of the Academy of Perinatal Harm Reduction. You can see my email at the bottom as well as our website. And do please check out our site and take anything that you find useful. And if something seems useful but needs a tweak, just let us know, because we are here to be useful and to our mission is very simple. It's just to improve the lives of pregnant and parenting people who use drugs. So any way we can do that, we're into it. This is everybody's favorite quote that I say. I became passionate about the rights of people who use drugs when I realized everything I'd been taught about substance use from childhood through nursing school was wrong. And it sounds kind of like hyperbole, but that's for real. And I think that's the case for most of us. And so when I do these trainings, I really try to approach it from meeting everyone where they're at. Most of you probably are not in Harm Reduction 101. You're probably farther along, but if you are in Harm Reduction 101, that's okay. We were all there at one point. It took me a lot of reading and researching to unlearn all of the stuff that I learned. So wherever you are in your journey, welcome. I don't have any financial relationships with anybody, unfortunately. If you'd like to begin a financial relationship, let me know. So basically, we're going to talk about methadone, buprenorphine, and naltrexone. Not as much naltrexone because it is not recommended in pregnancy, and we have a little less data on that, but we'll get to that a little bit later. And I'm going to kind of just breeze through some of the more general slides about what medications are and how they work and what they're for, because I think that probably most of you know that already. Sounds like most of you work in these kinds of clinics. So if there is a question, please put it in the chat and Adrienne can let me know, but otherwise I'm going to kind of try to focus more on the pregnancy related stuff. So we'll take a pause right here to see if there are any questions before we get going. Okay, I'll stop again in a couple minutes. So we're going to talk about those medications, what the goals of treatment are, what the advantages are, what the barriers are in the context of pregnancy. And we're going to talk about pregnancy outcomes. So this presentation is kind of focused on the pregnant person. Obviously, they're a dyad and cannot be separated ideologically, or any model that separates the pregnant person from the baby is not accurate. So we're mostly going to talk about the needs of the pregnant person, because that seems to be what gets neglected sometimes. So we're going to talk about dosing changes, pregnancy outcomes, breastfeeding, dependence exposure, polysubstance use, and alternatives to treatment. So hopefully everybody here knows the point is to stay alive, not become opiate free. Anytime that we are offering a treatment to a patient who has a potentially fatal diagnosis, goal number one is don't die. All the other goals are secondary to that. So we expect people to continue using substances. We know that relapse is normal and expected and not a reason to quit, or to quit quitting, if you know what I mean, to stop trying to quit. So with medications, and this is pretty much for everybody and pregnant people as well, our goals are improved stability. So that means people are taking a more regulated dose. They're not having those super highs and super lows of withdrawal. They're not spending a lot of time trying to get money to pay for drugs, trying to get drugs. You know, as Lou Reed said, the first thing you learn is that you always have to wait. And so it takes a lot of time and energy for folks. We see decreased risk of infection because folks are not injecting, not sharing needles, not using substances that may be contaminated. And we also know that methadone and buprenorphine are safe for human milk. Very little is transferred and even less is absorbed by the baby. So we'll talk about that a little bit later. We prefer treatment with medications, at least in the beginning, as opposed to attempting to stop cold turkey, especially in pregnancy, because it's already an extremely stressful time. For some folks, it could be considered a crisis even. So we don't want to throw another thing on top of all that. We want to try to help people stabilize their lives with the least amount of pain possible. And then particularly relevant in the context of even, you know, vaginal deliveries are quite painful. Ask anyone who's had one, they'll tell you, but especially in the context of increased risk of C-section, particularly for patients who have opioid dependence. It's not pain control. They still need their Percocet on top. So I want to talk a little bit about language here. I prefer the term OAT, or opioid agonist therapy, when we're talking about pregnant people. And the reason for that is, for those who may not already know, agonist means a medication that goes into the opioid lock and turns it on. There's also antagonists, which go into the opioid lock and turn it off. So when we're talking about agonist therapy, we're talking about methadone and buprenorphine. Naltrexone is antagonist therapy. And naloxone, of course, is a more famous antagonist, which has really strong binding capacity and locks out most other opioids while keeping the receptor turned off. But for pregnancy, mostly we're going to be talking about methadone and buprenorphine. We have kind of conflicting data showing that buprenorphine has probably slightly better outcomes for babies and for cost when it is successful as a treatment. But there are real issues with access. Who's getting buprenorphine versus who's getting methadone? And if you have a guess, you're probably right. Go to the next slide. So the obvious advantages of agonist treatment are decreased risk of death, improved social stability, like I said, not running around trying to access money or drugs all the time. Barriers are really just artificial. We could get rid of all of these things. Stigma, difficulty accessing these medications, and criminalization. Forgive me, I'm not familiar with what the laws are in Arizona. I know when I was working in NICUs there, I don't believe that the police or law enforcement were involved, but every time somebody came in on one of these medications, they were reported to child services, even if they had, you know, treatment compliance for years. I think one lady had been stable for 8 years and they still opened a case, and, you know, put in all these artificial barriers. Like that particular hospital wouldn't let people who were taking opioid treatments, they wouldn't let them stay in the hospital past 9 or 10 p.m. or something, kind of arbitrarily. So there's all these kinds of things that are all these messages that these families are hearing every day saying, you are not good enough. You are different from the other families. You don't deserve to stay overnight in the hospital with your baby. And so those barriers are artificially imposed by us, the healthcare system. And so that is the stuff that we need to smash. So comparing methadone and buprenorphine, with methadone, we do have a long half-life. That can be tricky in pregnancy because your metabolism for most people speeds up, and it doesn't slow down until the baby's born. So even with a long half-life, best practices are for people to get split doses, at least twice a day. I don't know if any of y'all have ever been on methadone yourself or have known folks who have, but I have been in a lot of 7 a.m. meetings with people on methadone. Even people who aren't pregnant, they have like this kind of real sleepy time after their dose. And then in the evening, they tend to, you know, get a little itchy. Like most people with decent dosing don't have too severe of withdrawals, but even though it has a long half-life, you still see that peak and then trough when it's time for the next dose. And that is especially relevant in pregnancy. We do see improved treatment retention with methadone in some studies, not all. And the reasons for that are not entirely clear. It could be the drug itself. So where folks we'll go down to the buprenorphine. Below, with buprenorphine, there's a ceiling effect for most people around 37-ish milligrams. And so if your opioid requirement is higher than that, buprenorphine is just not going to work for you. So I suspect that is one of the drivers, at least. And back to methadone, the barriers. Daily dosing is a huge barrier for anybody that has small children or is pregnant. You know, one of the hallmarks of pregnancy is called morning sickness, and having a daily early morning appointment is just, it's such a barrier. And a lot of this regulation is mandated by the law, which it is all of our responsibility to change. I haven't looked at the codes of ethics for every profession, but I know that for doctors, nurses, and social workers, if there are laws that are harmful to our patients and our clients, we are required by our boards and our codes of ethics to work to change them. So that's on us. And then there's other stuff that's just kind of intentional. The context in which methadone treatment evolved was one where people who use drugs were considered to be deviant and, you know, to have a disorder, not just a substance use disorder, but like to have something wrong with their personality and even their cognition. So we put in all these barriers, like the daily dosing, like the other requirements, having to participate in therapies that may or may not be useful or wanted by that client. Or like the hospital that I was talking about, where they kicked out people who used these medications at a certain time and allowed other parents to stay. Let me just tell you, that was so humiliating for these families, to be sitting in, you know, a room with multiple babies and families and have someone come in and say, okay, it's such and such o'clock, you have to leave. It's humiliating and it's unnecessary. And so I think that we can get rid of those intentional barriers that we impose quickly, and then we can work on the mandated ones with the law and all that stuff. So with buprenorphine, one of the benefits is decreased regulation. This is a medication that you can get from a doctor in a clinic. which is much more private than standing in line at a methadone clinic. You can get it filled at a pharmacy, and you don't have to go every single day. Now, for some folks, especially in the beginning, going every day is perceived as helpful. So that should totally be offered and on the table. But for most people, it's not ideal from a parenting, from a career, from almost any other perspective. With buprenorphine, it is a little bit more costly for most folks, and it may not be covered by their insurance as well as methadone. And then, yeah, appropriate dosing. We talked about that already. Methadone has that ceiling effect, which can be kind of an advantage or a disadvantage, which is why I sort of included it on both sides, because the ceiling effect is helpful for safety, because it's much harder to overdose on something that stops working after 37 milligrams. But if you need more than 37 milligrams, that's not going to be a benefit. So let's talk a little bit about naltrexone. We don't have data on naltrexone in pregnancy. And even in the general population, we don't see great efficacy data for it. Naltrexone or Vivitrol, which is the longer lasting medication, it's a blocker. It's similar to naloxone, but not exactly. It also works for alcohol. And so the theory is that it works in some kind of complex multifactorial way. And it really, what patients report on Vivitrol is that it kind of just blunts pleasure in general. So it doesn't feel good to drink alcohol. It doesn't feel good to use heroin, but it also doesn't feel good to be in love or to watch a funny movie. It just kind of feels like a little bit dull all the time. And for some folks, that is that's okay. Some people want to use naltrexone. Most people want to use it temporarily, get themselves some stability, and then stop. And then that's where we see the increased risk of overdose. So that's a really important concern with this one. One advantage of naltrexone is access. Everybody is totally down with blocking people's pleasure from using heroin. You can get naltrexone in a lot of places where you can't get methadone or buprenorphine, such as jails and prisons, because we have this. It's really strange, because if we evaluated these medications based on goals such as not dying, improved stability, and all those things, it wouldn't be really much of a contest. But because we don't like people feeling good when they take their medicine, a lot of folks push naltrexone instead. So I think that naltrexone should definitely be an option for everybody, including pregnant people, if they want it and they ask for it. I think that when we're counseling patients, we should guide them to gold standards that we know are going to have the best chance of being effective. But it's not up to us. It's not our body. It's not our baby. It belongs to the patient that you're treating. And so that's the person whose decision should matter the most. Our job, I tell my patients constantly, and they're always kind of like shocked. My job is not to tell you what to do. My job is to give you all of the tools that you need to make the best decision for yourself. And then even if I don't think that's a good decision, I'm still going to support you in that decision. And that's our role. There's so much of paternalism in medicine, and we don't need to get into the history of that. I always go over. I'm so sorry. All right, let's keep going. So outcomes. We expect polysubstance use, especially in the first months of being on treatment. Our goal is not necessarily abstinence, although that is a goal for many patients, and many patients achieve it. But if if a person goes from injecting 3 times a day to injecting 3 times a week, that is amazing and wonderful success, and a great opportunity to say that. Congratulations. One little safety issue is if the person is using benzodiazepines, which is really common, using benzodiazepines with opioids. It's kind of an adjunct, so it amplifies the effect. it could raise the buprenorphine ceiling, increasing the risk of overdose. So that's something really important to counsel all of our buprenorphine patients on. As far as treatment retention, there is some conflicting data about treatment retention in pregnancy with methadone and buprenorphine. Some studies find increased levels of treatment retention with methadone, and some find no difference at all. So the jury's kind of still out on that one. There's new studies coming out all the time about that. So dosing during pregnancy. Your blood volume increases dramatically during pregnancy, heart rate, for some people, blood pressure, it affects diabetes and insulin needs. And so of course it affects the dosing needs for pregnant people. And I was looking at one recent study that found that people starting out on 80 milligrams by the end of the pregnancy required 190 to keep their serum level the same as what it was before. There's another recent study showing that Black people receive about 2/3 the dose of methadone as white people. And that's really concerning, because we know that Black and other people of color receive substandard care in our NICUs, in our hospitals, receive substandard pain care. And it's not surprising, but it is alarming that this is also happening in our treatment systems. So that's something that we really need to fix immediately, yesterday. Dosing might need to be adjusted several times during pregnancy. Like if you're, if you're having morning sickness and you're puking your guts out every day, that affects your metabolism. If you are, develop gestational diabetes or gain a ton of weight, or there's just so many things that happen. So it really needs to be individualized with the expectation. I kind of always tell my patients this too. We have the average person, which is a myth and doesn't exist, and this is what we expect. But you are probably going to follow a similar course, but there might be some individual changes that we need to make. So we approach these patients with the expectation that they will require their dose to increase. And we should talk to them about that early on, ideally before pregnancy, because a lot of folks who are on methadone see increasing your dose as failure. And we want to just get rid of that assumption. The goal of treatment is to get to a place where the patient is not over-sedated and not experiencing withdrawal and cravings. It's quite simple. So you can't really evaluate those things without partnering with your patient and asking them those questions and believing them when they tell you. Even when, I was kind of surprised at those numbers, from 80 to 190 milligrams. That's well over double the dose that they were taking before. And that's just to keep their serum level similar to what they were on before pregnancy. So it really is important to believe our patients when they tell us that they need more. So with outcomes, there really isn't a lot to say here. We don't really see a lot of super negative pregnancy outcomes with patients on methadone or buprenorphine. And like I said, we don't really have data on naltrexone. So when we're looking at these studies, we have to take into account other factors. So like most of you, I've seen a lot of pregnant people who are taking methadone, and we do see a lot of associations. Sometimes the babies are smaller, some of them are born earlier, not all of them, most of them are perfectly fine. But when we look at the whole context, if we compare these babies to other babies whose mothers maybe have insecure housing and nutrition deficits, who smoke cigarettes, once we control out for all those things, we're really not seeing anomalies. We're not seeing an increase in preterm births or low birth weight babies. A lot of this stuff, especially when you control for cigarettes, disappears. Cigarettes we should put everybody on methadone and off cigarettes if we can. There are some studies that find a shorter length of stay for the baby with buprenorphine versus methadone, which is a goal of most parents, to not have their kid in the hospital for a long time. It's not totally confirmed though. What we have seen in most studies is that infant withdrawal is not dependent on maternal dose. There are some studies, I just saw one yesterday coming out that are finding that, but there's always kind of been conflicting data. So we'll have to wait and see on that one. Always encourage your patients to breastfeed. It's better for moms. It reduces the risk of postpartum mood and anxiety disorders, which we know are the #1 killer in the postpartum year after hypertension and cardiovascular related stuff. And we know that it's good for babies. I can't even list everything. The list is too long. I would run out of time for this presentation. So it is safe to breast or chest feed on methadone or buprenorphine. We do sometimes see reduced lengths of stays in studies. We're not totally sure why, because like I hinted at earlier, we see about a 2 to 3% transfer rate from a maternal dose into human milk. And then the infant GI tract really just kind of sucks at absorbing drugs. And so they're probably absorbing, 10% or less than even what gets transferred. So I think the real mechanism is skin to skin and family-centered care, because we know the many, many benefits of skin to skin, and we know that keeping families together results in better outcomes. We also have data showing that maternal serum, human milk, and infant serum levels don't seem to be correlated the way that we would expect them to. We need to do more research into this if we want to find an answer, but at this point it seems like there's too many personal variables in there to be able to make a generalization. So we'll talk for a moment about no treatment. This is an option that patients have a right to choose. And if they do choose it, then that's okay. We can maintain therapeutic contact. So perhaps the patient doesn't want to go on methadone. What else does your clinic offer? Can you maintain contact with that patient somehow in case they change their mind, in case after they realize that you're not a jerk, that maybe they will want to come to you for treatment? Everybody benefits from access to services, whether it's the parents or the baby. And I kind of just reiterate that several times on this slide, because if there's one thing that I want people to take away from this conversation, it's that babies want what's best for their moms, want what's best for their babies, and it's a circle. Families are not, they're connected. I mean, it seems like it's obvious, but somehow I keep saying it over and over again. There is a strong risk of overdose and death in the absence of treatment. So it's really important to offer these patients naloxone, which I know you all know all about. Let's see. So with detox, there is an increased risk of death, and that's related to relapse and overdose. We all know about that. Pregnancy is an incredibly stressful time, maybe not the best time to try detox, which is emotionally and physically uncomfortable, to understatement of the year. We do have some data that it can be achieved with reasonable safety. I would not recommend it unless the patient chooses it and is strongly, strongly motivated after a discussion of all the risks and benefits, and after providing access to treatment, not just, well, you're on the waiting list, we'll see you in 6 months. We don't really have data on what the best time to detox is. The consensus is second trimester. It is thought that there's a risk of miscarriage in the first trimester or preterm labor in the third. And so that's kind of what we're going with right now until we know better, until we get better data. Oh, and the Bell 2016 study that I cite there about the reasonable safety, that study was done on incarcerated populations who did not have a choice of treatment. So that already is a big uh-oh when we're interpreting this data. The other thing is they had a much higher risk of fetal or neonatal death than in the general population in their study cohort. However, most people did okay when compared to other imprisoned populations, which there's so much there's so many ethical no-nos when we're researching people in prison, for so many obvious reasons, but also it's really difficult to generalize that to people who are not in prison, because their lives are just so very different, and the quality of prison healthcare, and particularly prenatal and maternity care in prisons, is atrocious. So take that study with a grain of salt. Okay, I finished. 1 minute. I'm so sorry, I always go over, and I didn't stop to see if anybody had questions. So I will shut up now.
So we have just about maybe 1 minute for questions. And Maria, if you wouldn't mind putting the survey link up just in case anyone has to drop off right at 1. But what questions do we have for Joelle? Well, I have one, Joelle. You mentioned something about some of the families that are dealing with opioid use disorder are asked to leave the NICU early. I didn't quite catch that part, or what the rationale was for that, why they aren't allowed to stay the full time. Could you say more about that?
Yeah, that's not a typical hospital policy. I mean, it's some places do that. It's at this particular hospital, it was not a written policy. But all right, I don't want to bash nurses and healthcare providers, but nurses don't really read written policies. They just, if the charge nurse or somebody says this is the policy, then that's the policy. I love reading policies. Send me all your policies. I have a collection. But most of us are not doing that. So this was just this one charge nurse, and nighttime charge nurse at this one facility. She wouldn't tell me why. I asked a bunch of times, you can believe it. But she just said that she had a bad experience once, and I quote, she said, "This policy is near and dear to my heart." And that just made me want to throw up all over everywhere. But yeah, so it was basically just this one person who was in a position of power decided to implement this policy, and that's how it's been now for years. And it was just, not that this is about me, but it was really hard for me to participate in that, to go in and the baby's happy and snuggled and on mom skin to skin, and I'm sorry, you have to leave. But I think the hardest part about it was that the patients just kind of accepted it. Oh, of course I'm being treated like garbage. Of course I have to leave. And I think that was the most heartbreaking part of the whole thing. But most hospitals have some kind of weird imposition, something that they do for these families that's usually not in the written policies, because if it was, they would get their asses sued off. But it's just something that they do, and patients go along with it because they're used to being treated like garbage. And yeah, I don't really have a good answer for you because I was never able to get one.
Thank you for clarifying. Yeah, I was just trying to understand what the rationale might be.
Yeah.
I
don't know.
Over at this point, and I know some folks are dropping off. So I just want to thank you for your presentation and your case presentation. It was wonderful. I'd imagine folks can contact you offline if they have
yes, please.
If you have any specific resources you'd like us to send out as well with the post-session email, we're happy to do that. So thank you again. We really appreciate you coming back again this year. And I hope everyone has a great weekend, and we'll be back in 2 weeks.